Can kindly. Okay. Welcome everyone to California ACC's session today. It's called Can Digital Innovations Improve Equity and Diversity in Healthcare? I'm thrilled by and excited about the topic that we're going to address today, and also the superstar panelist and our amazing moderator. And I'm Jamal Rana. I'm currently serving as the president of California ACC, also the Northern California governor. And I'm here to sort of quick introductions. And Dr. Rodriguez is here, Dr. Ayala Somaya is here, Dr. Morfogel is here. And the good thing is, and Dr. Muse is going to be moderating the session. He's a catalyst for innovations. And the good thing is they all know each other. I was the only one who didn't know everyone. So it's going to be very organic and fun talk. And I just want to be upfront, thank everyone today who's joining us. I know there's a lot of Zoom fatigue, and especially our esteemed panelists. So Dr. Muse, take it away.
Yeah, thank you, Jamal, and thank you, panelists. I think this is going to be a really fun conversation today, and we want to make sure that the viewers, the folks that have tuned in today, are also part of this conversation. So as we go through, please use the chat function of Zoom to type in a question, and we can get that answered. This is a conversation. I think we've all been through now 2 years of lots of PowerPoints and slide decks. And, this allows the panelists, myself, to at least set things off and really dive into a little different conversation. The title is, Can Digital Innovations Improve Equity and Diversity in Healthcare? I think we've all heard now over the past 10 plus years how, supercomputers in our pocket, how, telemedicine, how novel sensors and new AI algorithms are revolutionizing medicine. And they are changing the way we practice and the ways we care for our patients and the types of research that we're doing. But it's also opened up new gaps and new layers of complexity. And it's taught us a little bit of sometimes we move too fast. Just today, one of my patients was elderly patient, couldn't get his video visit working. So we had to transition to phone, and other patients that don't even have smartphones and don't really want them. So it allows us to have this discussion about what are we missing with technologies, not only on the telemedicine front, not only from the sensor development and tracker front, but also from the algorithm aspect and the novel kind of risk assessment tools that we're using to date. How have we gotten here and where are we going? And from our panelists, we're going to focus on several things. We've got Fran Ayala Somayala, who's going to help us provide a picture about kind of population health, give us a 30,000-foot view of kind of how we got to the point that we are. She is president of REACH and CEO of RTL Innovations. I've had the pleasure of knowing Fran for the past number of years. And every time we get together, I get to learn so much more about the digital health tech space. She's been at the forefront of this, not only from larger companies, but also her own avenues as well. We have Fatima Rodriguez joining us from Stanford, assistant professor in cardiovascular medicine, to help us dive into a little bit about the patient care space, some of the aspects of her own clinic and the research that she's doing. And Dr. Julia Moore-Vogel, who is our director of the Participant Technology Center of the All of Us Research Program at the Scripps Research Institute here in San Diego, trying to again learn from that perspective, what are some of the novel ways that health innovation and digital technologies are helping lay the foundations of new types of research and what we're learning from these. When we look at the statistics, it's still 1 in 5 lack smartphones, 1 in 4 don't have access to broadband or internet, such as being in remote or rural areas. There are lack of care resources. And when we're talking about equity and diversity, it's not just on the racial standpoint, but it's also educational, from sexual orientation, from gender identity, from income, occupation, and even disease groups that people fit in that are sometimes pushed aside and not given the resources that they need. So welcome, and thanks for joining us today. Again, please use the chat section that we can help integrate your comments and questions as part of our discussion today. Fran, thanks for being here. I know it's been a busy couple of weeks for you.
Well, thank you so much, Evan. And it has been a couple of busy weeks, but I think it's been very well spent having the opportunity to engage directly across the country with organizations and institutions who are really focused in on this work of digital health and digital health equity. And I would say, to maybe kick it off, that perhaps from my perspective, as particularly being Reach, a global social impact organization, what we would like to invite to this conversation is, first of all, a clear definition on what we were referring to when we refer to equity. Because equity is not equality. Equality means that everyone has access to the same thing. And, you know, that doesn't necessarily work for everyone. The simple example that I often give is the idea of handing everyone a stool. If everyone on this webinar were given the same height stool, it doesn't mean that everyone's still going to be able to reach the top shelf. So how do we make sure that individuals, that all of us are given access to the tools and the information we need in order to be successful in our own health journey? And that's one of the things that we really are very much focused on. And this becomes so much more apparent when we're talking about the use of digital health technologies. Yes, the health literacy aspect is one component of it, but it's also about the readiness of individuals. How many of you all are coming to this webinar after a really long day at work? Just put a yes into the chat window for me there, right? You're probably exhausted. You've either spent the day running between patient to patient, or you've been, like so many of us now, inundated with emails, the charting, right? Having to chart, having to do teleconferences, telehealth sessions, teleconsult with patients, having to make phone calls, all kinds of craziness. So the ask that's being made of us to, even as professionals, we would think, you know, ourselves to be in a special bucket or category who may not need to have adjustments or modifications or accommodations made for us. We too require accommodations. So when we're talking about digital health, we really need to think about it in that context, that everyone has something that they have needs around. And even when we leverage technology, like telehealth as an example, doesn't mean that it's always the appropriate tool to be used for an individual. And we have to take that into consideration. We know from the pandemic that while, yes, there was this increase in utilization of telehealth technology as an example, that it wasn't actually all that sufficient. We only had about 30% adoption and many other places where it could have been utilized. And in fact, amongst all the telehealth that was used, the majority, as Evan was alluding to, was actually via telephone. So we really have to think about, well, what does this mean? The other element is the burden that we put on our patients. Now that we're asking to utilize remote patient monitoring, to utilize telehealth as an example, we're putting ourselves in a situation where the burden is actually shifting to the patient. Used to be that, you know, you go into a clinician's office, the clinician is wearing the stethoscope, right? The clinician has the blood pressure monitor and all the other necessary peripheral biometric devices for measurement. But when you shift to a telehealth environment, teleconsult, remote patient monitoring, you're now shifting that burden to the patient. And for many individuals, unless they are traditionally someone who's already been with pre-existing conditions and have access to those tools, the majority of individuals don't have access to blood pressure monitors or other things like stethoscopes. So how are we making sure that the tools that are necessary for us to perform and be optimal in this now digital space works for everyone and works for them well? I'd love to kind of hear from my colleagues, and I'll perhaps pass it back to you, Evan or Julia and Fatima, if you want to chime in here, because I want to I'd love to hear your thoughts on it. And I know that there's so much more for us to explore in the conversation.
Yeah, Fran, you've served such roles with large digital health companies. You've worked so much with startups and small groups, and you've just gotten back from South by Southwest, where there's probably been so much going on in the health tech area. Do you think that companies these days and even startups and other tech groups, do you think they're thinking about things to make sure that we close this gap and we're here to address these needs rather than just, like you said, giving everyone the same size stool? Are they making potentially the next round of innovations? Are they making them customizable to make sure that we're addressing different care gaps out there? What have you seen the shift like over the past few years?
So the shift I have seen is that these institutions and these manufacturers and startups would all attest that absolutely they are, because they have a focus group, right? I mean, that's basically the way that they describe it. But how many of them are really prepared to spend time directly within communities? I think back when I started my career working with the World Health Organization and doing work with the U.S.-Mexico Border Association, SHUMBA, and it brings me back to the times working with migratory farm workers as an example, where when we wanted to understand what the needs were and conducting community assessments to be able to determine the right approaches to providing care, we didn't bring people into us. We would go out to the people, be in the communities, and speak the people's language. And that was really important in our ability to create programs at that time, in the time of HIV/AIDS epidemic, as an example, where we were able to be more successful in our response because we were going out into the community. And we're really not seeing that sufficiently being done today. I'm going to give you sort of a far off example that will be kind of eye-opening. And that the example of that is the autonomous car, the autonomous driving car. You would think that these cars were designed for everyone to utilize. And the first group that would come to mind are those who or have disability needs. The largest minority is the disabilities community, over 1 million people with some form of disability. And yet the autonomous driving car is not designed for the disabled community. And even trying groups like the United Spinal Association, who are trying very diligently to bring manufacturers and innovators in to participate with them, struggle to get them to come to the table and to engage them in activities. So these are unfortunate realities of what we're really seeing. It is insufficient to say that we're designing in ways that are universal, because universal principles and universal design is so critical, but it's insufficient to say that we're doing that by simply providing opportunities for a handpicked select few to participate in focus groups. It just doesn't suffice.
Great point. Julia, Fatima, any additions there?
Yeah, I mean, Fran brings up such wonderful points. I found myself nodding all the time, especially with the example of telehealth. So I am a clinical cardiologist and focus on prevention, and a large part of my clinic is through telehealth, and that's been a shift since the pandemic, and a shift that's here to stay. So I will say on a positive spin that it's been great to have patient-generated health data really be part of our clinical encounters. Again, that wasn't the norm. So what would happen prior encounters, a patient would come in, their blood pressure was high. They say, as Evan knows, no, my blood pressure is normal at home. This is just what it is in that clinic. So we just have a starting point for shared decision-making and discussions. And again, it depends on the patient. So I agree with Fran that you can't have a one-size-fits-all approach. But I found that to be a huge gain of health tech and data as we move to virtual platforms. I check on patients a lot more regularly with telehealth than I used to again in person, because for a lot of patients coming to Stanford, even parking in Stanford is just basically they have to take the whole day off work. And I'll say that the other advantage of telehealth is that I'm actually able to see their built environment, where they live. So when I have my elderly Spanish-speaking patients, often with a grandchild, helping them connect to the telehealth appointment, I actually get an insight into where they live. I'm like, let me see your medications. Let me see what you're doing to give you recommendations that are more consistent with your actual lifestyle and what's realistic. And I'll say that the other space where I think health tech has made huge gains during the COVID pandemic is in the area of research and clinical research and clinical trial recruitment, which I know Julia can speak more about. As an example, and I know my colleague Raj Dash is also on here from Stanford, decentralizing clinical trials has been a huge gain. And the Stanford Apple Heart study showed that, right? That we enrolled virtually over 400,000 participants in 8 months. And that's just not how clinical trials are done in cardiology. And I think that wearing that clinical research hat, we realize we can actually probably get more diverse participants, more people in the community, and do things with a lot lower participant burden than we've done historically in the way we used to do things. So I think a lot of times it's challenging the way we think is the norm for clinical care with telehealth and the norm of what we think is normal for clinical trials with the standard, high participant burden in-person visits.
Good point. One of the striking thing, you think of you brought up the Apple Heart study, and this was a group that already had, smartwatches, right? A certain level of income level there, and a certain kind of wellness acumen that people are thinking of. And even those that were asked to potentially wear the patches, as follow-up, it seemed like there was a lower percentage than what you would expect of those that had abnormal. So here's kind of an informed, potentially higher income population that's even potentially dropping the ball a little bit in really high-tech, cool research. And then we look back at our community patients, et cetera. What is potentially that disconnect, and what do we need to do better within our connectivity or innovations to, I guess, make sure we don't lose patients who need it the most, whether it's in research or within our patient care?
Yeah, and I would love to get Julia's thoughts on this. I think from exactly the example with the stool, you need to do more for certain patients to get them even to the same level. So what that means for my clinic for patients that don't speak English as a first language, that means that somebody in Spanish has to call them and prepare them for that appointment. And we have to make sure that there's an interpreter available if necessary for that appointment. And that takes extra steps. But again, these are not surprise visits. So that takes extra planning, and that is absolutely necessary. The same is true for research, right? If we want people to be digitally inclusive and have a diverse representation, we may have to give the Apple Watches. We may have to do extra teaching on how to transmit that information. We may have to have a study coordinator go to that individual's home and gather the data and help people get that data. So those are just some examples. And I know that Julia has been doing this with the All of Us study that is purposely designed for diversity. So I'd love to kind of learn from her.
Yeah, no, what you're saying is all right on, both of you. I'll just tell you a little bit about the All of Us research program in case folks aren't familiar with it, but it's an NIH funded study to enroll 1 million participants across the US that are meant to be reflective of the US population, to share all different types of health information, biosamples, et cetera. And it's meant to be a 10-year study with 1 million people. So the scale is quite large. And we just released last week our first genomic data to the research community with almost 100,000 whole genomes, including 50% individuals who self-identified as a racial ethnic group other than white. So it's a really great asset to the rest of the research community, where it's usually at least 80% white individuals in genomic data sets. So we're really excited about that. Now, keeping people, first of all, getting to people is a challenge, right? Getting to the diverse group of folks that we want to is really a challenge. There are a number of different barriers. One of them is the program is digital, which has two sides of the coin, as we've been discussing. That for one thing, it enables geographical and racial and ethnic diversity, which has been demonstrated in multiple studies now, that by having a digital study where that doesn't require people to come in person, you can increase diversity. But it also requires people to either have the tools or go somewhere where they have the tools to be able to enroll and stay engaged. And so what we focus on at Scripps is making it possible for everyone across the country, anyone that's interested, to raise their hand and volunteer for the study. And so we focus on making sure that it's accessible digitally and that people are supported digitally as much as possible. That includes having a support center that's available all day in English and Spanish, by email, phone, or chat, depending on whatever the user wants. But in other parts of the consortium, we're really focused on the higher needs, harder to reach populations, where they're not just going to read something on a website or read an email or a flyer and be self-motivated to join, because they have a lot of questions and they want to hear from someone in their community in a lot of cases. So we have a number of community partners, I'd say over 50 probably, across the US that have helped us, one, develop materials that are culturally sensitive and appropriate, and two, reach out to folks in their communities. We also have federally qualified health centers that are reaching out to their patient communities and able to talk to folks as part of their normal care, and make sure that they're really a trusted partner together in the research. So that's in terms of accessibility. In terms of retention, it's an ongoing challenge, I think, everywhere, right? One of the things that we found that's the most helpful is when you're giving something back, unsurprisingly. If we're giving folks the tools like a blood pressure cuff, like a Fitbit that they can use to send data to the program, that's helpful. We also give genomic information like ancestry, traits, which are things like, are you lactose intolerant or not, which people are really excited to find out, even though you would think they already know. And also clinically actionable genomic information like the ACMG, incidental finding variants, and pharmacogenomic variants. So we try as much as possible to make it a give and take with the participant, where they're giving us their information and we're telling them what we've learned about it. That's really interesting. I don't know how much I built on your questions, but go ahead.
Can I jump in on that one?
Yeah, of course.
Ben, because Julia, I love 3 points. Number one, working backwards, the comment you made around really allowing people to have access to the data itself, their own personal insights, and helping them to be able to interpret that, because that's a really big key. It is so insufficient to say, oh, well, you need to start to monitor your blood pressure, but we don't take the time to help them figure out, well, number one, what is even the appropriate blood pressure monitor to utilize? Like, how do I go out selecting one? And then how do I utilize it? And once I've utilized it, okay, you've given me a number and I'm supposed to be looking at something within this threshold, but what am I supposed to do with that thereafter? Like, what are the steps here? And that in of itself can stress people out, which can make those numbers even worse. So how do we deal with that? And I just love the fact that you have that follow through component. When we think about participation in clinical trials, one of the Achilles heels is that people, rightfully, in my opinion, fear the unknown. They don't know what it means to be participating in something. And when the information is going into, the abyss, and they never hear back from what's going on with the data themselves, that just opens the door for, feelings of anxiety or mistrust or doubt and apprehension about participating. So I think that makes a really big difference. The other two, just really quickly, that you pointed on were around leveraging partners directly in communities, localizing the initiatives. And many of the initiatives I've done both here in the US as well as globally, where we found the most success is where we have community-based organizations directly in the community that people recognize and trust being at the forefront of the work that's being conducted. And that's what allows for people to, number one, want to engage and want to stay engaged. And then the added component around that is really creating for localized experiences and hybrid models. And I think, Fatima, you brought that up as well, right? This idea of utilizing community educators, health educators, individuals, again, directly in the community who people who recognize and they trust, and that really enable for more affordability, in the sense that it's not all about the tech that makes things work. And I think that that's one thing, Evan, you're asking about, like, where are folks going? Well, where I see a lot of the industry going is these extremes. We're trying to attempt to go from one extreme to another, which is putting everything digital, and in many respects, it's inappropriate, and we need to strike this balance.
So there's this need for this human component, or this soft approach to usher people in, because there's still amongst certain communities a certain distrust, not only of medicine and the system, but also of technology, right?
Mm.
So, you know, I thought one of the cool things, and you touched on this, as did Julia, in terms of these community partners to end up doing this education. You know, specifically, Julia, have you tried, you know, has the program tried, you know, direct outreach versus going to the communities, partners, to see if, when you're using that certain kind of human outreach, et cetera, to build that trust, that you get a better buy-in?
Yeah, we've tried everything. So there's no one size fits all for anything. So I would say there's two extremes. One is we have some non-traditional partners that we do outreach with, like Blue Cross Blue Shield, WebMD, Walgreens, that just have massive reach and are interested in helping to keep people healthy. So they will do, you know, email campaigns or social media campaigns where, you know, a lot of people will see that and decide to join the program. And they don't need a lot of education. They don't need a lot of, you know, reassurance about what's going to happen with their data. There are certain personas of people, we call them ready to go. They're just like, yeah, if I can do something to help with medical research, I'm in. So that's one extreme, the people that just need a single email or see a tweet or something. And then the other extreme is the community partner and the FQHC folks, where, you know, it makes sense that a lot of people have hesitations, particularly about one, participating in research, and two, giving their data to a program run by the federal government. And so there's a lot of conversations that need to be had about trust and privacy, what we do with the data, how we protect it. And, you know, we always say we can't 100% guarantee that there's not going to be a security breach, because that's just life with the internet. And so a lot of folks will choose, after all of that discussion, not to join, and that's okay. That's their choice, right? But almost, I would say the top question that we have is, what are you going to do with my data? Who's going to be able to see it? How are you going to keep it safe? And we do try, you know, to Fran's point about it going into the abyss, we do try to give updates on what's happening with the data. So we have this cool newsletter that goes out every 2 weeks called My Medical Minutes, that summarizes different research studies that have been done, not necessarily in the All of Us research program, but we highlight the ones that have been done with All of Us research program data, so that folks can see what's happening with their data. And it's actually, the concept is based on Eric Topol's Twitter feed, for anyone that follows Eric. So it's the idea that, you know, he's always summarizing things, and it's so helpful. I don't know how he reads it all, honestly, but we do that for our participants in really layperson summaries to help them see this is what's happening with your data, and to educate about medical research in general. You know, when this is an embarrassing anecdote, but when I was in high school, I thought research was going to the library to look things up. I had no idea about this whole world of actually discovering things. I didn't learn about that till college. And so I think there are a lot of people in the world like that you need to educate them about why medical research is even important before you can get them to the point of saying, okay, now give us all your data for this purpose.
I completely agree with what you've just said, and what Fran said about this bi-directional relationship with data, right? And at Stanford, with the Google Baseline project, that's a partnership with Verily and also with Duke. I mean, the participants want their data, right? And they want the digital tools so they can get their data. You know, they're getting something back, and they want to know what we're doing with the data. So now that the study has been going on for several years, we have community forums, we share the publications in lay terms to say, okay, this is how you're contributing to science. Because I think in general, people are happy to do so as long as there's transparency around the data sharing, around the consent process.
Great point. You know, I want to touch a little bit. We have a question that Ankush asked via the Q&A aspect here, and I want to address one of his big questions and also invite more. So anyone that has questions, you know, based on things we've talked about or different directions, feel free, use the Q&A or chat. It all lights up red on our side. But one of the big questions that Ankush asked is, in terms of looking at industry, how should industry be actively assessing what good looks like as we move into the future, in terms of saying, all right, who sets that roadmap, and what are the data points that they need to be looking at for this community? Any thoughts on that?
I have sort of a controversial perspective that I'll share, which is, you know, I went to business school, and, you know, we know that everything's all about, maximizing shareholder value. But I really hope that goes away to some degree, that I feel personally that corporations have a responsibility to try to do what they can to make their products as useful as possible to the broader community. So, things like, for example, in the All of Us research program, we make sure that everything is up to disability compliance standards so that, screen readers can be used and things like that. I would love to have, to Fran's point earlier about the self-driving cars, to have companies think more about equitable access. Can people with disabilities use your product? Can those that don't have the digital savviness coming in get the support that they need to be able to use the product? So that's an important thing for me.
I think from a practical point of view, I would see as a win, especially as you think about drugs and devices in the cardiovascular space, when the people that you're studying parallels the people that have the disease. And we know that is absolutely not the case at all right now. We know that minority and underserved communities and understudied communities, broadly defined, are just not represented in the clinical trials. And we have an evidence gap. So I think that's the win. And I think that's what we're moving for. And it shouldn't be an optional. It should really be, I think, mandated.
Great point. I think it's hopefully little by little with novel innovation, we can bring in these underrepresented groups because, it's time to start studying those patient populations as well. Fatima, speaking of that certain level of trust, in a healthcare system, they haven't always been great partners per se, but this is changing. What concerns do your patients voice about, the healthcare system being more involved in their data in terms of connecting, whether it's, home monitor systems, et cetera, being able to get the cloud of data, the IoT, and potentially use it for benefit in the future?
Yes, this comes up all the time with all of my patients. Mistrust is really an important barrier, I think, as we think about implementing a digital transformation of healthcare for all our patients. And it's understandable, right? So I have a lot of Spanish-speaking patients that I see that are illegal, and they're worried that their immigration status may be questioned, and that the same with vaccines, or if they go get tested for COVID. So we want to, in research and in delivering essential healthcare, we want to collect the minimum necessary information. And again, I think that this is true for vaccines, and we've seen it with COVID vaccines, and then be very transparent of where this data is going. And I'll give an anecdote, as Julia did, a personal, kind of petty anecdote. My daughter is in preschool, and they asked, who wants to test their kids for COVID? And I'm like, great, do the COVID, do the COVID test. I signed the papers, and all of a sudden I start getting results back that contain more than COVID testing. They're testing for influenza. They're testing for random viruses. So they're just using my daughter because she's a willing participant to just kind of get a feel of what kind of bugs are circulating. I was so upset about this, not because I care. I mean, great if they know about influenzas, because they were not honest in what kind of data they were collecting. And I've lost complete trust. So I said, I don't want you ever, testing my daughter for anything without my consent. And they said, well, it's the same swab anyways. Don't worry about it. And again, I said, it doesn't matter. That's not the data you said you were going to use. So we're done with that collection system. And again, it's a small example without huge implications for somebody who is a savvy parent, but imagine our patients who are less savvy and all the concerns that they have about sharing their data.
Well, that's mishandling informed consent, right? So failure to get informed consent, and that's very concerning. One of the populations that we work very closely with and provide digital solutions for are in the maternal health space. And the platform that we have created is in part designed to address things like gestational hypertension and preeclampsia. And we know that in the maternal health space, as an example, that non-clinical data is very important to be able to support the needs of both the mother as well as the child. And the result of that is that there's a much larger story that can be told around the conditions of the home environment, the healthy or unhealthy state of the relationship between the parents. There's a lot of factors, a lot of information and insight that we're getting, and it becomes very questionable to individuals as to how that information is going to be utilized. It's incumbent upon the designers of these tools and manufacturers of these systems to uphold a code of ethics. And it's one of the things that we're very much charged with. We're working with some of the leading societies that are focused on information management, and we are putting forth a call to action for a manifesto that is focused specifically on the protection and security of data that's being generated, both clinical as well as non-clinical, through digital health applications for that very reason.
You know, Fran, I'm glad you brought that up. It seems like in the US, we've really failed at maternal and fetal health, and it's how and why, and it's very frustrating to know that we can't protect the most vulnerable populations during that time. What do you, you know, as you roll out your project and support there for that, what do you see technology's role specifically, then allowing it to be different from regular clinic-to-clinic outreach or community health programs? So is there a specific pivot point or fulcrum where digital health innovation will play a big role? And I know that you know, Julia is also involved in some fetal and maternal health projects at Scripps as well. So if there's any comments, would love to hear.
Yeah, I'll be very brief to just say communicate, you know, it's just that connecting, communicating, and collaborating, right? That's the big key. When we look at the causes of what we know to be over 65% preventable, it's really associated with the delays in knowing the signs and the symptoms, delays in transportation, delays in diagnosis, and unfortunately misdiagnosis, and delays in treatment. And if we can utilize the technology to gather those insights and be able to take preventive measures, so we have the opportunity to prevent a lot of not only mortalities, but for every mortality there are 10,000 plus morbidities. So we really have an opportunity to do a lot of significant good. And Julia, please add to it. I'd love to know from the perspective of the project that I know you guys are very much involved in as well.
Yeah, so our study is called Power Mom, and it's really about looking at maternal fetal outcomes and trying to understand what's behind the disparities that we see. Another interesting project that we're looking at that's part of that is looking at discrimination and perceived racism and how that affects outcomes as one driver of potential differences in outcomes, because we know Black maternal health is very poor across racial and ethnic, across income levels. And so, there are things that we don't think would be barriers to care that would be driving it, but there must be something else there. And so, and we know that racism is a problem in this country in general. So that's a natural thing to study there. I also wanted to build on Fatima's point about patient collaborations in research. This is something that we've especially seen be important in the long COVID community, which unfortunately I'm a long COVID patient. And so I have a lot of thinking about this that I've done, but we saw in the early days that one of the major papers about long COVID symptoms and characterizing it was led by patients who are sick and still, leading the charge and, starting to show what's important about the disease. And I think in that disease, particularly where it's so easy to minimize given the nonspecific symptoms and, things like fatigue being really prominent that, can sometimes be discounted, I think it's absolutely critical to have patient involvement. And I totally agree with Fatima's point that we should have patient involvement be mandated in studies across the board, because there are just things that you don't know unless you have the lived experience that can make a huge difference.
If I could add to that, Evan, really quickly, I would say I'd love to see it go just one little step further and make that a criteria when providers are in the process of electing what digital tools they're going to utilize as well. I think, the question needs to come when these suppliers and vendors are coming forth with their solutions, that we're asking the question about how did they design and who's participated in that design, so that we're making sure that it's reflective of the populations that we're serving.
That's so critical, Fran. So we have, again, being in this area, we have so many startups, so many students come to us and say, look what I've designed. I've designed a 8-headed stethoscope that the patient can put on and you can, and I'm like, who's going to use that? What patient is going to use that? Is, somebody that's in your engineering class. So we actually mandate that any collaboration or any study that they come shadow us in clinic that they do patient engagement, they do all the necessary HIPAA training and everything to really be able to get in that perspective. And most of them don't like it because they want to be fast, right? And they want to do something. And I think the space of healthcare in general, and especially the space of equity, it's important to not skip steps in the design, the user design and the testing. And again, some things that may seem like a good idea may not pan out equally for all groups. And we really need to study that.
No, I love that. Certainly, you know, I think sometimes that's how we got left with the quality of our EHRs now, you know, being designed by
Billers.
technician. Yeah, exactly. You know, I want to get to Shivani's question here, and Fatima, maybe you'd be able to take this. You know, I think that long COVID, as Julia was talking about, I think it's like a great place for some of our existing digital tools. You know, our heart rate monitors, blood pressure monitors, movement trackers, scales, etc. And there are so many on the market. Sometimes there are certain patients that come to us, you know, that probably shouldn't have a tracker or shouldn't have a smartwatch, and it can drive, there's certain times that it can drive health anxieties, or at least I've seen, you know, we must match the patient to the tool and make sure that they all know what the data that's going to come out at it. Otherwise, we can create people that are nervous wreck. So Shivani's question here was, how do you lead communication around tech that is not particularly certified, such as an Apple Watch, when patients want to use it for monitoring? What's your approach to those sort of folks?
Comes up all the time, and a lot of urgent clinic visits and distress from my patients of, oh, my monitor said, talk to your doctor, you know. So I think a lot of them have warnings to say this is not 100% accurate, or my Apple Watch says the rhythm is irregular. I think they're useful, but I usually say, okay, you know, that's a tool for us to have a conversation, and then I'll do a Zio patch or something that we use more often in clinical practice. Some of these tools are very helpful around virtual visits, especially when we were seeing patients that didn't live close by. So I think I did rely on them. Again, as a starter, I said, the deal is don't interpret it yourself. Send it to me. You know, so send me the PDF of the attachment. And a lot of times it's artifact, as we know that happens a lot, and these tools are not perfect. But some of them I'm like, oh wow, they really did pick up something that suggests atrial fibrillation. Let's do, you know, the standard monitor and the standard evaluation, because with a lot of these tools, there's going to be a lot of noise. And I think, as I think Fran maybe said, putting that burden on the patients, on the participants to interpret that noise is challenging. But there's certainly a role for it. There's nothing, of course, that I recommend. I don't have any commercial interest, but some of these tools are very helpful. My mom has, to your example, has permanent atrial fibrillation. And I told her, okay, get a cardio device because you're going to call me anyway, so I could see, you know, and send me what a mess. I get this every single day. I get like, hey, look, I'm in atrial fibrillation. I'm like, you've been in atrial fibrillation since, you know, 1995. Like, this is not a new finding, but now you're aware of it and it's making you anxious. So let's tone down the monitoring. So totally fair, Evan, that comes up a lot in our patients, but definitely useful. And sometimes have picked up things like atrial fibrillation where I would have not had a pretest suspicion for that.
I'll just add really briefly, in the long COVID space, patients have found themselves that the devices can be really useful for pacing, basically managing their energy because they have such limited energy. And so it's been really interesting to me. This has just sort of emerged out of the patient community, and it's something we're working to study more rigorously at Scripps. But that's sort of the opposite side. Instead of it being, you know, flagging something that's wrong, it's actually helping you implement something that can help with your health.
I think there's a challenge, though, in all of this. This is considered, that we refer to this as patient or personal generated health data. And for this is an awesome panel. And so the clinicians that are sharing their insights and experiences have that long time experience and confidence with the data and with the technology. That's not really reflective of the reality of physicians that are out there. You know, there's plenty of studies. Ipsos Mori every year since 2015 puts on the Digital Doctor Survey. We know from the Digital Doctor that while clinicians are very eager to utilize technology, they lack the training and therefore lack the confidence. And as a result of that, the majority of clinicians do not accept personal generated health data because they themselves don't know what to do with it, don't know how to communicate it. So I think it's incumbent upon groups like the ACC. That's why I'm so glad that we're having this webinar, because it's necessary to begin to put forth more opportunities for training so that more clinicians feel comfortable in guiding patients and helping them to be able to do that interpretation or to recognize when it's actually doing more harm than good for a patient and steer them into the direction of something that's more appropriate for them, as opposed to just putting on the brakes and saying, no, I don't accept this, I won't work with this, or why are you using that? I think we need to be cognizant of the fact that we also need to support clinicians in this journey to adoption of digital health. There's a health equity or inequity that exists amongst practitioners' utilization and integration into their practices.
And Fran, I'll take it one step further and say it's the system. So not necessarily even the individual clinician, right?
Absolutely.
Because you want this to be, when I get these PDF attachments and I'm trying to finish my notes, and and this is where I think tools like artificial intelligence are a little bit more clever way to handle so much data. Can we summarize it? Can we synthesize it? Can we have EHRs that speak to each other, right? So if my patient gets care somewhere else, I don't have to translate that data into our health system. So I think that's really where the opportunity for the systems to actually be helpful to integrate this data.
Indeed.
I think I'm hearing some of the themes that we talked about even when doing participant-based community research, et cetera, is that education is a big part of this, even for physicians. And, I completely agree with the comments that were made. So I want to welcome any final questions from the group here, and as anyone thinks of kind of any final questions they may have, I'd like to wrap things up with our panelists on some closing thoughts in terms of we've talked about access, we've talked about education, community partners, hybrid models, meeting our patients with disabilities, with diversity in areas where they are, and start learning their system and what's meaningful to them, to have innovation then help them on their journey, not necessarily impart our will and wishes on them. As we move forward, as startups, as large industry, as academia, as private practice docs, as all the groups come together, I guess, what is everyone most excited about? And then I'd say is, what is the biggest opportunity that they see, that they're excited about seeing that change happen to empower diversity and health equity using digital tools?
I can go. I think I'm just excited about the day when everyone has digital literacy. I know where the federal government's slowly working to get there, so everybody has broadband access, et cetera. But I think when we have that as a level playing field, it's going to be huge. And I think it will really enable us. I hope that there's a continued trend toward enabling us to get participants in research, patients in the clinic, data into their own hands so that they can really be more active in, understanding themselves, and hopefully it can motivate them to be more adherent and do more for their own health.
Great point.
Yeah, and I can agree that I think when being able to use digital tools is going to be a social determinant of health if it isn't one already. And there was a JAMA, I believe, cardiology editorial on that. I think I'm really excited about the opportunities for digital health to improve population health management, both as a clinical tool, really making it easier to make the right choices for the right patients and reduce practice variation for things that we know work, but also as a research tool to identify gaps and users that are not being met by this. As you said, patient engagement, awareness, bidirectional feedback, the conversations we've had about that, again, both in the clinical and research space. And then in the research space, I'm really excited about how we can use these tools to tailor diverse recruitment of patients into clinical trials and collect more patient-generated data of how people are feeling. The patient-reported outcomes are always underutilized in the care that we provide our patients.
I'm really looking forward to personalization. I think that's the biggest key, where the data is allowing for us to be able to really personalize care for individuals, but also to empower individuals to make personalized decisions and to be truly part of the decision-making process. I think it's also important, and that we'll be at a point where we've arrived when we've recognized that it's not just creating access to digital tools that's a social determinant, but it's actually the ways in which we go about utilizing it. If we look across the current day 5 categories of social determinants of health, it's a mismatch and misnomer to say access to digital technology or internet is sufficient. It's actually around the behaviors associated with that, which are the real markers for the determinants of health. And that's why we've been emphasizing that with REACH in our proposition to the United Nations on the inclusion of it, not as just an access point, but in terms of how people utilize it, because we know that tech can also do equally as much harm as it can do good, depending upon how people are consuming it and the choices that they make from it, which is more than just about having access. So.
No doubt. Thank you all so much. As I was, planning this discussion, I started to think about the negatives and where we've left off and things we haven't done right, and groups we need to connect with better using digital technologies, and knowing that you all are on it, and the ideas and growth and things that you have put together. Actually, I'm leaving so much more excited about the future and about where we're going. So thank you for that. I've learned so much through even just a brief conversation here. And I want to thank the California ACC for making this a priority and helping us put this on the map and to grow this conversation out even more. So panelists, thank you so much.
Yeah, I just want to add, Evans, that I was listening in the back, and to your point, like I was really worried about the whole thing, structural racism and how the things are, like how will we catch up with all this, right? But as I listened to all the discussion today, I became more hopeful. So thank you all for thinking about it, and thank you for coming today and talk about it and made awareness. Like every bit helps, right? And to Fatima and Dr. Rodriguez's earlier point that 2 years ago there was a discussion, we have to get more get on the virtual care, and nobody was like, how could we could do that, the old model? And then suddenly the switch flipped. And so that was a silver lining, that at scale and so fast. But it also showed us that with COVID-19, the disparity also came out. So I think the next thing, or the next challenge for us, is to scale it fast and do it and get to it, and not let it get away, this opportunity in the midst of this challenge. So thank you, everyone. And we should have them back, and you guys are welcome. Reach out, and we should continue these discussions and let us know how else we can support and promote this work. So thank you. Yes.
Thank you.
Great. Thanks for having us.
Thank you so much.
Thank you so much.